Recording.
We are recording.
Good morning, everyone that's joined so far. We're just going to give it another minute or two before we kick things off. Good morning, everyone. I see the attendees number still growing. We're just going to give it another minute before we get started. All right, I think our attendees has slowly, people joining has slowed down. So we're gonna go ahead and get started. Good morning and happy Friday, everyone. My name is Carly Schilling. I'm the Senior Compliance Manager for Magellan Behavioral Health of Pennsylvania. And welcome to our 2022 Annual Compliance Forum for our contracted Health Choices Medicaid providers. We are always pleased when providers want to participate in this voluntary training. We really appreciate the interest and commitment of providers to be compliant with Pennsylvania Medicaid regulations and Magellan guidelines. We do strive to be transparent with our provider network and make a commitment to provide all the tools and resources we can to help protect the financial integrity of the MA program. So today's training is actually very timely. If you didn't already know, next week from November 6th through the 12th is National Corporate Compliance and Ethics Week. This event is intended to shine a spotlight on the importance of compliance. So if you don't already recognize or plan to recognize this important annual event, we hope you will consider doing so in the future. And perhaps you can use some of the content from today's training to help promote Compliance and Ethics Week within your provider agencies. Next slide. So before we get into our formal agenda, I'm going to introduce the team who will be presenting today, and then we'll review some basic housekeeping items. So this slide is our designated PA Health Choices Compliance and SIU teams, the majority of which are presenting today. We have 3 claims and compliance auditors dedicated to our Health Choices contracts. They include Tina Davis, Patty Marth, and Caitlin Vosberg. Despite the county designations you see on this slide for the auditors, they are not exclusively assigned to those counties. Caitlin primarily conducts auditing activities in Bucks and Montgomery. Tina primarily works with Cambria County providers, and Patty, who is the SIU team lead, primarily works with providers in Lehigh and Northampton counties, but there also is considerable overlap. So you might hear at any point from one of these auditors in your daily work. And Diane Devine is our senior team lead for investigations. She will be doing a presentation for us today. Holly McQuiggan will also be participating in today's training. She is our senior compliance coordinator. And then Tanya Pennington is the manager of our Special Investigations Unit. This is a great team, and they have a lot of knowledge and experience related to compliance, the Health Choices Program, and Medicaid, as well as fraud, waste, and abuse. Next slide. So today's training is part of our ongoing effort to ensure that we provide education and support to our provider network related to compliance and fraud, waste, and abuse. We have prior trainings posted on our website, and the link to those resources is shown here as a hyperlink. And then after today's training, we will post this 2022 training there as well. Today's training is scheduled from 10 to 12 o'clock. The training is being recorded, and we will share the PowerPoint presentation, a link to the recording, and the Q&A responses to all registrants in the coming days. Everyone, all participants are muted today, but there is a question and answer option through Zoom, and we hope you will use that to ask questions during today's training. The chat feature is disabled, so you'll only be able to use the Q&A feature to allow questions, and then that allows us to get a report at the end of the training so we can respond to everything. At the end of each section, we will try to address as many questions as we can from the Q&A and provide a verbal response, and anything that is not answered live, we will follow up with participants with a written response. We will also send a survey to participants following the training today to get feedback and ideas for future trainings. Next slide. And now this is our agenda for today. We're going to talk about some positive outcomes we have seen in our oversight in the last year. We will talk about some 2021 and 2022 audit trends. This is the #1 requested item from our providers every year. Next, somewhat related to audit trends, we'll review regulatory reminders that come up most frequently. We'll talk about the current status of telehealth, the public health emergency, and regulatory suspensions. Then Diane Devine will do some highlights and share a true fraud story that may be helpful for providers. We'll share some resources related to E&M coding. We'll talk about some confidentiality reminders. And then finally, we will review compliance plans, ethics, and some other reminders. One final thing I wanted to mention before we get started, something new that we have not done in prior compliance trainings. We are going to incorporate poll questions throughout today's training to try and make this as interactive and engaging as possible in this online forum. So please be ready for that little wrinkle. We'll prompt you when those poll questions are going to be displayed on the screen. You're not required to play along, but we hope you will participate to make this a little bit more interactive. So now I'm going to turn it over to Patty, and she is going to kick things off with some positive outcomes from the prior year.
Thank you, Carly. So on this first slide, I believe it says it all. I just wanted to highlight the collaborative approach between Magellan and our providers regarding auditing. I believe, this slide highlights our process, how we own it, we deliver, we win together, we care, we stand tall, and then we evolve. That is the whole process around doing our auditing. So everybody, does evolve and does the best that they can with our members. So I just wanted to highlight that slide. Next slide, please. So here on this slide, as you could see, from 2015 to September of 2022 is the average claim rate, average error claim rate, and also the compliance scores. As you could see in the claims error rate from 2019 to 2020 and 2021, there was a significant decrease in the claims error rate and a slight increase in 2022. My personal opinion, as this has something to do with the 2020 and 21 has something to do with the PHE and also COVID and everything that was happening. And now we're kind of getting back to somewhat normal, and that is what we are seeing. Also, the compliance scores were relatively consistent, except for in 2022. But in 2022, we did add to our compliance tool the telehealth policies and procedures, which providers were actively working on. So I just wanted to highlight those. Next slide. So next, I'm going to highlight some overall audit trends. Some of the things that is a constant that we are seeing is no documentation, no progress notes for services billed, billing for missed appointments. And as a reminder, Medicaid members cannot be charged for any services. And also another high level is documentation standards not met. And some of the details with that are times not on progress notes, dates not on progress notes, staff not signing with their credentials. One of the things that I know we always say is take credit for what you do. And, you know, your staff has worked very hard to get the credentials that they have. So therefore they should be signing with those credentials. Also, for folks that still have paper records, some of those progress notes are difficult to read or legibility, and error correction, such as, you know, items are scribbled out. We also want to remind with the correct place of service, and I know that this is a bit newer due to the whole audio only, having different modifiers, and also the telehealth having different place of service. So we wanted to highlight those, that those are things that we are taking notice in our overall trends. And also just a reminder regarding the treatment plan requirements, depending on the level of care. Next slide. So just to continue, I did mention previously the correct modifier combination based upon your Magellan rate sheet. Also, electronic signatures occur prior to the end of session. So basically, a staff is signing their note at 11:45. However, the end time on the progress note says 12 o'clock. Also, something that is definitely an audit trend for this year is separate billing for all-inclusive services. So per diem rate you receive includes reimbursement for all necessary ancillary and laboratory services needed to care for that member. And also billing for non-billable service, such as transportation, social activity, or administrative duties. So those are some of our overall audit trends that we have seen in the past year. And at this point, I will pass it over to Tina to take a deeper dive into IBHS.
Thanks, Patty. Some specific IBH trends that were found when we did implementation oversight audits of IBHS providers in 2022 were similar in nature to the overall trends, and then some are a little bit different based on the level of care. Some of the trends found during these audits related to staff signatures, and Patty mentioned earlier, staff signatures not being accompanied by credentials. All signatures need dated, and that was not happening in all cases. All signatures must include the complete name of the staff and not just initials. Progress notes were found not to support the number of units billed on a consistent basis. Documentation in the progress notes did not tie back to the goals in the treatment plan on all occasions. If you ensure that the documentation is included and ties back to the treatment plan, that would actually kind of kill two birds with one stone and strengthen the progress notes to better support the units billed. Another one was correct place of service for the environment that the services were being provided in did not match what it should have. All handwritten notes were not legible, which was also found in the overall trends. And time in and time out should be documented in real time and not always clock hours, because in our real In the real world, this doesn't happen that way. So it's important to document actual times. Also in the overall trends was the correct error procedures. Just remembering that errors should be crossed out with one line initialed and dated, and errors should not be scribbled out. Magellan requires assessments for IBHS to be updated every 6 months, even though the IBHS regulations state 12 months, and this was not consistently followed. Assessment should also be updated when authorization is requested to continue or any change needs made based on additional needs or things being, progress being made more rapidly than expected. The full contracted unit duration, for example, 15 minutes or 30 minutes, depending on what the service is, must be provided to bill a unit. Rounding to the better part of a unit is not permissible in IBHS. Next slide, please. So some of the telehealth audit trends: consent, audio only, telehealth, and place of service coding. There have been some changes. One of the major changes when providing services via telehealth is around consent. During the initial period of the public health emergency, OMSAS and Magellan permitted general verbal consent that was documented by the provider to accommodate the rapid transition for telehealth services for providers. This general method of the verbal consent is no longer acceptable and permitted. OMSAS 2202 adheres to the exceptions of Act 69 of 1999, the Electronic Transfers Act, which is an electronic sound, says that an electronic sound is considered a type of electronic signature. So now we need to have a traceable consent. So we have to have an audit trail for these consents. Providers are not required to get another signature for consent at every session like they were in the initial part, but you do have to have an audible trail for the consent. So you can get that consent face-to-face before the telehealth visit starts, or if you have an EHR that allows an electronic signature that is traceable via the audit trail, that is fine as well. Effective July 1st, 2022, and currently, providers should use the modifier FQ in the last position of their modifier position, along with any other contracted code and modifier combinations, anytime a service is provided via the telephone. So FQ is a modifier to indicate that the services were held for phone only and there was no face-to-face interaction. In accordance with OMSAS 2202 as well, providers must either place a service code of 0, 2, or 10 when rendering a service via telehealth. When the member is at home, and this is member specific, when the member is at home, the place of service is 10. When the telehealth session is provided, when the member is at a location other than their home, that would be place of service 0, 2. So remember that it's the physical location of the member and not the provider. Next slide, please. More on the telehealth audit document. Audit trends is documentation. So we talked a little bit about the 15 minutes and the 30 minutes, that the unit definition must remain the full 15 minutes or 30 minutes, depending on the service, to bill a full unit. Services also must be provided in accordance with the member's treatment plan or service plan or recovery plan, depending on what it's called in the level of care you're providing. In accordance with Magellan's telehealth guidelines that were issued during the COVID-19 disaster declaration, Providers must clearly document a telehealth session. In addition to the minimum documentation requirements that are listed in the PA Health Choices Provider Handbook Supplement, the following information must be included in the record for each rendered telehealth service. At intake, the documentation must include the member's consent to receive services in this manner, and that would take care of the getting the consent that is traceable in an audit. Now that verbal consent is no longer accepted. The documentation must indicate the mechanism for how services were delivered, either telehealth or phone. And then you also need to document the platform that was used, for example, Zoom or DoxyMe or whatever platform that you use if it is via telehealth. And the documentation must include the member's phone number if phone was used. Next slide, please. Next slide, please. Thank you. You will notice that if you've had an audit recently, you will notice that our compliance plan tool has an extra section this year, and that is section C, and it is about telehealth policies and procedures. OMSAS and Magellan require providers to have telehealth policies and procedures. All telehealth policies must include these 6 components at the very least. These components are found on the compliance audit tool, section C, like I just mentioned. And it is sent to you if you have an audit with all of the tools in the confirmation letter when it is scheduled. The requirement for these policies and procedures is outlined in the OMSAS bulletin on telehealth, so they're just not a Magellan requirement, but an OMSAS requirement as well. They include policy on their operation and the use of telehealth equipment, policy around staff training for telehealth, policy around a contingency plan for transmission failure or other technical difficulties. So we need to know, or the members need to know, what happens if you lose a connection, if you can't get connected, those kind of things. Number 4 is policy that addresses how to handle emergency situations, such as risk or harm to self or others when services are being provided by telehealth. And this is, the emergency situation would be if something comes up, a risk to harm yourself while you're in the middle of session, what will happen and what will be followed. Number 5 is policy on appropriateness for telehealth and how that will be determined. And number 6 is a policy that describes how interpretation services, including sign language, will be delivered for individuals if needed when using telehealth. So staff should receive ongoing training on the use of telehealth, and providers are encouraged to keep updated on any changes that are made to the guidelines. Telehealth FAQs can be found on the Magellan of PA's website. I will now pass it to Patty.
Thank you, Tina. I am now going to review some trends regarding the Center of Excellence, or COE, audit trends. So just a few reminders with the Center of Excellence is a reminder about individualized care plans. So just some highlights that the members, it should include the members' treatment and non-treatment needs, preferred method of care management, such as face-to-face meeting, phone calls, or through secure messaging application, the identities of the members' community-based care management team, as well as the members' identity of their support system. Also, service duration. During the audits, we've seen more of a check-in of the service duration. They were very limited on an average of 10 minutes or less. So we want to ensure that the services that are delivered are documented appropriately, and also the times are documented appropriately. Also, there was minimal community outreach or minimal linkage to community supports, either that being other services or community-based services, or anything such as Al-Anon, all of those things. We saw limited. Some of the providers we actually audited, there was just some pamphlets that were handed out, no true linkage. We want to remember that the Center of Excellence is the hub of the wheel. Next slide, please. And as far as documentation standards regarding with the Center of Excellence, we want to ensure that there is the date of the encounter, location of the encounter, identity of the individual employed by the COE with whom the member met with, the duration, the description of service that it was being provided, and the next plan activity and member will undertake. We also seen a clear duplication of services between the COE and members having other CRS and SUD case management services. So we want to ensure that there is no duplication of services when it comes to the Center of Excellence. I'm going to pass it over to Holly now to see if there are any questions.
Thank you, Patty. All right, just a reminder, everyone is invited, if you have any questions for the previous session that was just reviewed, to type it into the Q&A and we will respond to that. While we're waiting for people to do that, I'm going to go ahead and launch our first poll question. All right, all-inclusive means that the per diem rate you receive includes reimbursement for all of the necessary auxiliary and laboratory services needed to care for the member. True or false? Okay, I'm going to go ahead and end the poll. And the answer for this question is true. Looks like 85% of our respondees got it right. Okay, I'm going to move on to the next poll. Telehealth documentation standards includes at intake. The documentation includes the member's consent to receive services. The documentation includes the mechanism for how services were delivered. For example, telehealth or phone. The documentation includes the telehealth platform that was utilized, for example, Zoom, if applicable. The documentation includes the member's phone number that was utilized, if applicable, or all of the above. Going to end the poll and share our results. The answer is D, all of the above, which 97% got correct. All right. With that, I'm going to pass it back to Caitlin.
Hi, good morning, everybody.
Sorry, before we do that, we do have some questions that I just want to make sure that were addressed. Several of them were answered within the Q&A, but I'll just mention questions about the signature stamp of both the client as well as the clinician. The example was if the individual is seen from 11 to 12 o'clock and the patient signs the note at 11:57, clinician signs at 12 o'clock, is that okay? Yes, we're looking for the rendering staff signature. That's what signifies the end of the session. So the rendering staff signature should not precede the end time of the session on the progress note. There was also a question about telehealth consent. and if it needs to be signed prior to each session. And no, that was a recent change in the telehealth bulletin from OMSAS. It only needs to be signed at the start of telehealth, not for each service, not for each session. And we'll actually talk more about that later in the session. Go ahead, Caitlin.
Great. Thanks, Carly. Good morning, everybody. I am going to go over some regulatory reminders for a variety of different levels of care. Next slide, please, Holly. So first up, we have group requirements. For psychiatric outpatient groups, the requirements include that there be no less than 2 participants and no more than 12. Group sessions must be conducted by a clinical staff person. For substance use disorder outpatient clinics, again, no less than 2 participants and no more than 10. Sessions must be a minimum of 1 hour, and sessions are conducted by clinic staff under the supervision of a physician. For both of these levels of care, adding an additional group facilitator does not allow a provider to double or expand the size of a group. Regardless of the number of provider staffs co-facilitating or leading the group, the maximum allowable size without an OMSAS waiver is 10 for DNA clinics or 12 for mental health clinics. LPHA referrals, a recommendation from a licensed practitioner of the healing arts or LPHA, is required for peer support and certified recovery specialist services. An LPHA is limited to or defined as a physician, a physician's assistant, a certified registered nurse practitioner, a psychologist, licensed clinical social worker, a licensed professional counselor, or a licensed marriage and family therapist. The rounding of units, I know that Tina mentioned this a little bit when discussing IBHS. So providers must bill for full units of service, and rounding is not allowed according to MA Bulletin 999706. So the number of minutes, either 15 minutes, 30 minutes, etc., that equates to a billable unit is dictated by the state's covered service grid as well as your Magellan contract. So there are some exceptions, targeted and blended case management, crisis intervention, and family-based service, but this does not include, CPS, CRS, or DNA case management services. Next slide, please, Holly. So encounter forms, providers are required to obtain signed encounter forms to certify that a member received a service according to MA Bulletin 998905. Signed encounter forms should be present at the time of a Magellan audit or review. So providers are allowed to develop their own encounter forms. We don't have, nor does the state have, a specific encounter form or required encounter form that you must use. However, there is required information that must be present on the encounter forms. That includes certification statement, the provider's name and their MAID number, the member's name and their ID number, the member's signature or the signature of their parent, guardian, teacher, etc., the date of services, start and end time of services in actual clock hours, not the duration. So for example, 2:30 to 4:30 p.m., not 2 hours. The rendering provider or staff member signature. And if a provider is not able to obtain a signature on the encounter form, for example, if the member or their guardian refuses, it must be documented why, and they should make attempts to obtain the signature at the following session. So providers of community-based services such as IBHS, blended case management, CPS, CRS, they're required to obtain a signed encounter form or verification form for each face-to-face or telehealth contact that results in a claim being submitted to Magellan. And we will discuss the encounter forms for telehealth in a later section. Now I will pass it over to Holly for some poll questions.
Thanks, Caitlin. All right, our first poll question for this section is, what is the maximum number of participants you can have in a mental health group under an outpatient clinic? All right, I'm going to go ahead and close the poll and share our results. The answer to this question is 12. Moving on to the next poll. What's the maximum number of participants you can have in a substance use group under the under an outpatient clinic? Okay, I'm going to go ahead and close it. Share the results. And the answer for this is 10. Moving on to our next poll. For which levels of care do you need a recommendation from a licensed practitioner of the healing arts? This is multiple choice. Okay, I'm going to go ahead and end the poll and share the results. And the answer for this is both A and B. So both the certified peer specialist as well as certified recovery specialist. Our next poll for this section is, in which levels of care can you bill a unit which when the better part of the unit is provided? You round it up. I'm going to end the poll, share the results. The answer is family-based services and targeted care management. Our next poll and final one for this section is community-based services need to have encounter forms with what information included? Select all that apply. All right, I'm going to go ahead and end the poll and share the results. And actually, the only item on this list that is not required is the signature of supervisor. So all these other elements are required to be on the encounter form for community-based services. All right, that's it for our poll questions. It does look like we have a few Q&As in the queue. Carly, would you like to take an opportunity to answer any of these now?
Let's have Caitlin finish this section and then we can get to Q&A at the end.
Okay, sounds good. So passing it on then to Caitlin.
Thanks, Holly. So some more regulatory reminders for travel and transportation. So travel time and time spent transporting members for most levels of care is not reimbursable or billable to Magellan or the MA program. Regardless of your level of care, your program, or whether it's billable, you should clearly demonstrate the time spent traveling or transporting members in your progress notes. If it's not billable for your program or level of care, it should be separated from the time spent providing services, for example, the billable time. Staff should comply with their own internal agency policies regarding travel and transportation members. Regardless of your agency policy, for the most part, these activities are not billable. Some exceptions are are the centers of excellence and family-based services. Other than that, for the most part, travel time and transporting members is not reimbursable or billable. Documentation standards. So the full outline of documentation standards can be found in the Magellan PA handbook. Currently, they are on pages 60 and 61. So some of the documentation standards include that the record must be legible throughout. The member name and ID must be on each page. Entries must be signed and dated by the rendering provider and should include their credentials. Alterations must be signed and dated using the correct error correction form as Tina went over earlier. Progress notes and documentation of treatment, regardless of the level of care, must include the specific service that was rendered, the date of service, the name of the staff who provided the service, the place where the services were rendered, the relationship of the service to the member's treatment plan goals, including the goals, objectives, and interventions used, the progress made at each visit, changes or responses to treatment, and the actual time and clock hours that services were rendered to the member. Next slide, please, Holly. Some more reminders. These are specific to the ACT, so Assertive Community Treatment Team. So the minimum requirement for all ACT teams is to average 3 face-to-face contacts per week across all members. ACT services are currently funded through an APA or alternative payment arrangement. Providers are required to submit encounter data for all their members. Encounters should be submitted throughout the month, the service month, to reflect the ongoing services that are being provided to members. The claim that includes the bundled payment for the service month should be submitted in the first week following the service month and may not be billed prior to the submission of the encounters from the prior month. If no encounters are billed for a service month, then the provider may not bill for their APA payment for that month. Then regarding CRNP, PA, and RN services in outpatient clinics, outpatient clinics may bill for office, outpatient, and med management visits by a CRNP, a registered nurse, or a physician assistant, a PA. CRNP and PA's prescribing practices are defined by the licensing boards and regulatory requirements. A CRNP must have a collaborative agreement with a physician who holds a current license to practice in Pennsylvania. A physician's assistant or a PA must also have a written agreement with the supervising physician. A CRNP must have a certification as either an adult psychiatric mental health nurse practitioner or a psychiatric mental health nurse practitioner. The PA codes allows a CRNP or a PA 2 years to obtain their certification. RN activities in a licensed outpatient clinic may include administering meds like injectables, taking BMI measurements, educating members about medications, and assessments of medication effectiveness in consultation with a physician. According to the PA code, an RN shall undertake a specific practice only if they have the necessary knowledge, preparation, experience, and competency to properly execute the practice. Therefore, it's recommended that nurses working in behavioral health clinics are board certified by the American Nurses Credentialing Center as a psychiatric mental health nurse or an RN-BC. Next slide, please, Holly.
Okay, we have 2 more polls now to share with the group. Our first one is, in which level of care is transportation with the member billable? All right, we're going to go ahead and end the poll. Share our results. The answer to this question is family-based services. Our next question for this section is, which of the below is not part of the required documentation standards for all services? Close the poll and share our results. The answer to this question is duration of the session. That's the last of our poll questions for the moment, and I'm going to pass that back to Caitlin to continue.
Thanks, Holly. So these are some regulatory reminders regarding bed holds and therapeutic leaves. They are guidelines for the reimbursement of time spent on therapeutic leave in hospital, reserve days while in placement in an RTF. So if a member is admitted for a continuous 24-hour period to an acute general hospital, rehab hospital, or the rehab unit of an acute care general hospital, a psychiatric hospital or unit, and the child is expected to return to the RTF, Magellan will reimburse the RTF to reserve the bed for the child's return to the facility. Payment for hospital reserve beds is 1/3 of the facility's per diem payment rate. It is limited to 15 days per child per calendar year. So the 15-day per calendar year is cumulative. So therapeutic leave is defined as a period of absence from an institutional setting. And therapeutic leave is limited to 48 days per calendar year. There is required documentation for therapeutic leave, and it includes an order from a physician or a psychologist, description of the desired outcome on the therapeutic leave, start and end dates and times of the leave, and a written evaluation, resulting from interviews with both the child and the family after the leave period, and describing the treatment objectives of the leave and the outcome. The facility must report therapeutic leave usage, and therapeutic leave cannot exceed 4 nights/5 days per episode. If a member does not return back to the RTF from a therapeutic leave, the date of discharge will be the date of the last night that the member spent in the RTF, and reimbursement will not be provided for that episode of leave. Next slide, please, Holly. Reminders regarding credentialing, licensing, and MA enrollment. Providers are required to maintain both active licensure with OMSAS and/or DDAP and active PA Medicaid enrollment at the rendering and contracted site location for all contracted levels of care. If you anticipate moving your contracted location, you must notify your Magellan network specialist immediately to ensure that the appropriate actions are taken to transition your contract and MA enrollment. Providers must notify Magellan in writing within 10 days of any changes to their facility license, such as suspension, revocation, limitation, initiation of an investigation, charges of malpractice or professional ethical misconduct brought against the facility or any of the staff members, and any changes to a staff member's licensure or privileges. Magellan must also be notified in writing within 10 business days of any changes in ownership, executive management, or any other information that's contained in your credentialing application. All-inclusive billing rates and documentations. So most of the 24 hours levels of care like acute inpatient, detox, residential rehab, and RTF are contracted with Magellan as all-inclusive rates. I believe Tina mentioned earlier, but it might have been Patty, inclusive rates include all clinical, ancillary services, diagnostic, and professional services related to that member's behavioral health diagnosis. Separate billing for any clinical, professional lab services are not permitted. In compliance with the daily per diem rate that encompasses both treatment and room and board costs, it is Magellan's expectation that providers of all 24 levels of care, including drug and alcohol providers, implement behavioral health interventions for each day of service that's billed, including weekends and holidays. Staffing patterns must align with OMSAS regulation bulletins, as well as DDAP licensing requirements to allow for meaningful treatment. In accordance with this requirement, it's Magellan's expectation that each day of service billed will have corresponding documents in the member's records. Next slide, please, Holly. PAHC is the Performance Outcome Management Service. It's a database maintained and managed by the PA Department of Human Services that contains data regarding MA enrollees. It serves as a basis for producing performance measurements and indicators. Reporting of PAHC data is mandated at certain points in treatment by PADHS from mental health providers, including when you're seeing the member for the first time, the last time, and whenever there's a change in any POMS element. Magellan has a web-based tool for collecting POMS data, and effective July 1st of this year, information must be submitted online through the Magellan provider portal. Paper and hard copies are no longer accepted. Next slide, please, Holly.
Okay, we have another few polls here as well as a Q&A. So I will share our first poll. In order to bill for services rendered, you must have an active license, be MA enrolled, and be credentialed and contracted with Magellan. True or false? And the poll and share our results. And yes, this is true. Our next poll. All right, the reporting of POMS data by providers is mandatory by DHS to collect priority population data on every Health Choices member receiving mental health services. True or false? Okay, gonna end the poll and show the results. This is true. All right, I don't see any open Q&As right now. Carly, are there any that you would like to share?
I'll just mention a couple, and yeah, please, if folks could follow along in the question and answer. I am trying to answer most questions in writing within the Q&A, but I'll just mention a couple for the benefit of the full group. There was a lot of questions about encounter form requirements for outpatient. Magellan has never required signed encounter forms from members for clinic-based in-person services. Providers are more than welcome to implement signatures or encounters for those sessions, but Magellan does not require them. And the distinction being, we do require them for face-to-face community-based services, such as in the individual's home, the school, or somewhere else in the community. They would be required. So I wanted to make that distinction. There were several questions about that. Reminder that we will be making the slides available after the training, as well as a recording of this training, and all the Q&A question and responses will also be made available to all the participants. There was a question about the size of group therapy in partial. It did used to be 10 for both outpatient mental health as well as partial. There were updated outpatient regulations issued a few years ago, which expanded outpatient and partial group size to 12 individuals. DNA outpatient, however, continues to be 10 individuals max. All right, we're going to move on now to the next section, which is telehealth and status of the federal public health emergency. So on October 14th, the Department of Health and Human Services extended the federal public health emergency an additional 90 days. If this is the last renewal, then the PHE would end on January 11th of next year. The federal government has also reported that it will notify states 60 days before the PHE ends. So if this is the last renewal, then that 60-day advance notice of the end of the PHE will be issued by November 12th. In addition, the president created a built-in 151-day extension of these flexibilities at the end of any PHE. So with that extension, the current flexibilities would be in effect until June 2023. Under the PHE declaration, Pennsylvania was required to continue medical assistance coverage for most people except for a few exceptions. Those included if the individual moved out of PA, if the eligible recipient passed away, or if someone requested to terminate their benefit. So those are the only three circumstances in which someone would lose their PA Medicaid eligibility. We also want to make sure providers are aware that DHS has a public health emergency landing page with resources. The link here on this slide will take you to those resources. When the federal PHE ends, DHS must reach out to see if people are still eligible for medical assistance, and MA recipients will have to complete a renewal to maintain their MA eligibility. Please help communicate this message to the members you are serving in order to assist them in maintaining their eligibility and direct them to the helpful resources that are available through this link. Next slide. All right, so now moving on to PA regulations. It is important to note that the federal PHE does not have any impact on the regulatory suspensions in Pennsylvania. Any suspensions of PA regulations are purely under the domain of the PA legislature. So Act 30 of 2022 suspended various regulatory provisions under the PA emergency declaration until October 31st, so that was last week, unless they were reinstated sooner. And many PA regulations had already been reinstated back in 2021 or earlier this year. But as of November 1st, most of the suspended regulations have been reinstated. The text on this slide, suspended regulations, is an active hyperlink that will take you directly to a DHS website where you can find all the PA regulations that were suspended at one point under COVID-19. Once you are on this page, if you scroll down to the OMSAS section, you will see all the OMSAS specific regulations that were suspended at any point. There are several regulations, however, that were recently permanently suspended by Act 98, and we'll get to that on the next slide. Otherwise, full compliance with all regulations, including those that were previously suspended, must be in place unless providers have requested and been issued a waiver from OMSAS. And we'll also talk about the waiver process in a few minutes. OMSAS has stated that the suspensions of all the bulletins that are listed on this particular slide will end on 12/31/2022. So portions of these bulletins were suspended per a communication by OMSAS back in February of 2021. The temporary suspension of these non-regulatory guidance documents was intended to supplement the regulatory suspensions as a result of COVID. And just a reminder that bulletins are not considered regulations, which is why they weren't included as part of the governor's legislature suspending regulations. Okay, as I mentioned on the previous slide, and hopefully many of you are aware from a recent OMSAS communication, or I should say prior OMSAS communications going back at least a year, they had expressed a willingness to seek legislative action to permanently suspend specific regulations. And then on 10/28 last week, that legislative action took place in the form of Act 98, which permanently suspended the following regulations. PA Code 1153.14, which prohibited the telephone delivery of services. PA Code 1223.14, which prohibited the telephone delivery of services, and PA Code 5230.55, which required face-to-face supervision. So providers will no longer need a waiver and can provide audio-only telehealth for outpatient mental health, outpatient DNA, and partial hospital services indefinitely. This is a permanent change. The regulations will be updated. Please remember, however, that providers may use audio only when the individual served does not have access to video capability or for an urgent medical situation. Otherwise, audio and video telehealth platforms should be utilized when providing telehealth. The other change here was that for psychiatric rehab services, it previously required supervision 2 times per month in a face-to-face format. The face-to-face language has been removed, so supervision can be provided virtually through a telehealth platform. So now I wanted to remind providers about the waiver process as a result of most OMSAS suspended regulations now being reinstated. Back in March of 2022, OMSAS developed a request for waiver form and a newly revised information and guidelines for providers regarding waiver submission document to assist providers when submitting a waiver request to OMSAS for a licensing regulation or bulletin. The document provides detailed instructions on how to request a waiver to ensure comprehensive submission. And this revised process was really designed to ensure that OMSAS obtains all the information they needed on the first submission in order to reduce delays. Providers should also reference OMSAS 1603, which outlines the waiver process. And the steps you can see on the slide here, which I won't review in detail, that walks through the actual process for how to submit a waiver. But again, that's outlined in that bulletin, OMSAS 1603. Okay, moving on to telehealth. First, just thought it would be helpful to show a snapshot of how telehealth has evolved since 2011. That was the first OMSAS bulletin that was issued, titled Guidelines for the Approval of Telepsychiatry. This bulletin limited the availability of telehealth to MA enrolled psychiatrists and licensed psychologists only. Then in 2014, OMSAS issued updated guidance. This bulletin clarified and reissued the guidelines, but again, telehealth was still limited to psychiatrists and psychologists. It is important to note that telepsychiatry and telepsychology were rarely used or billed prior to 2020, mostly limited to the limited scope. Then in February 2020, right before COVID-19 became a worldwide pandemic, OMSAS issued OMSAS 2002, which expanded the use of telehealth to include CRNPs, PAs, LCSWs, LPCs, and LMFTs. There was barely any time to put these new guidelines into practice. On March 15th, 2020, the public health emergency was ordered and OMSAS issued a memorandum called Telehealth Guidelines Related to COVID-19, which added the temporary flexibilities for telehealth service delivery. That memo was revised and reissued in May of 2020. And then OMSAS incorporated most of these flexibilities into a non-COVID-19 related policy with the issue of OMSAS 2109 that was issued in August of 2021 and then reissued in September. So OMSAS 2109 was in place until July 1st of this year when OMSAS issued OMSAS 2202. The purpose of this bulletin was to update the guidelines for payment of behavioral health services using telehealth technology. The key changes of this new bulletin were to clarify place of service code billing, which Tina talked a little bit about earlier. Place of service 2 should be used when telehealth is provided in the location other than the home of the individual being served. And POS 10 should be used for telehealth provided in the home of the individual being served. Again, this is based on the physical location of the member. The new bulletin expanded the ability of licensed practitioners who serve less than 5 individuals to request approval to deliver services using telehealth if they do not have a physical location in Pennsylvania within 60 minutes or 45 miles of the area being served. And lastly, the new bulletin clarified the continued allowance of verbal consent, as well as the allowable documentation of consent, which we'll get to in more detail shortly. So let's talk about telehealth and HIPAA next. Telehealth equipment must meet all state and federal requirements for the transmission or security of the information and comply with HIPAA. There has been a lot of flexibility in this area since the start of the pandemic. The United States Department of Health and Human Services has continued to state that they will not seek punitive action against a provider who is not using a HIPAA compliant platform until the end of the PHE. When the federal PHE ends, punitive action may be taken against entities not adhering to appropriate privacy protections. So providers should be either meeting currently or working towards these expectations. Neither Magellan or OMSAS will promote any specific telehealth platforms. With that being said, this is a list that OMSAS recently gathered, and we wanted to reshare with providers. These are known HIPAA compliant video technology platforms. There may be others, of course, but these are some suggested vendors. So let's talk about member consent to receive services through telehealth. Again, this was one of the questions that was asked earlier in the presentation. First, as we all know, since the first telehealth guidelines were issued, providers must obtain consent from the individual receiving services or their legal guardian prior to rendering services via telehealth. The newest bulletin clarified that consent to receive telehealth is required only at the onset of services, not for each session. With that being said, please note that consent to receive telehealth is required for every different service that is being provided by telehealth. So for example, if you have an individual in treatment with you that's receiving outpatient peer support and case management services, and all three are being rendered at least partly through telehealth, the member must consent to receive telehealth for all three of those services. So there must be 3 different consents for each service, if that makes sense. A reminder that providers may not mandate that an individual receive services via telehealth. It's a member's right to choose, and that consent must be ongoing. So even if they consent at the beginning, they may change their mind later and want to return to in-person services, and providers must accommodate that. Ongoing assessment for the appropriateness of telehealth is also required. Members should be assessed on a routine and ongoing basis for the clinical appropriateness to receive services via telehealth. OMSAS 2202 has a list of factors to consider when determining the appropriateness of telehealth. Also, one reminder about the consent of an individual to record telehealth sessions. This is separate from the consent to receive services via telehealth. So if you want to record a session, whether it's in person or on a telehealth platform, the member or their legal guardian must consent to that recording. Okay, so now that we've clarified when consent to telehealth is required, how should providers document the consent of the member? Per OMSAS 2202, signatures for consent may be physical or electronic signatures. And again, Tina covered some of this earlier, but never hurts to mention it multiple times. Under the prior telehealth bulletin, OMSAS allowed general verbal consent that was documented to accommodate the rapid transition to telehealth. However, in the new bulletin, this is no longer permitted as a general method of verbal consent to treat as an acceptable practice. But we should also mention that verbal consent that was given under the guidance of the previous bulletin is acceptable, and providers will not have to go back and obtain a new documented version of verbal consent under the new requirements. So the new requirements are only going forward. You do not have to go backwards. Moving forward, providers will need to get either a physical or an electronic signature. So just break that down a little bit. Physical signatures may be obtained through a variety of different mechanisms: in person with the member, through the mail, emailed forms to members who have the capability to print and return hard copies, or print, scan, and email copies. Providers are also welcome to come up with other creative ways to obtain members' physical signatures. If you've developed a method that's working, we would welcome you to share it to assist other providers who might be struggling with the requirement. So now that we've addressed physical signatures, which are pretty straightforward, what encompasses an electronic signature? Per OMSAS 2202 and Act 69 of the 1999 Electronic Transaction Act, an electronic signature is an electronic sound, symbol, or process attached to or logically associated with a record and executed or adopted by a person with the intent to sign the record. Providers using electronic signatures must have systems in place to ensure there is an audit trail that validates the signer's identity. The requirement is to create a permanent record of the consent. And the easiest way to do that is through a telehealth electronic platform. An example of an allowable electronic signature could be captured, an example of an allowable electronic process for electronic signature includes a telehealth platform where there might be a checkbox for an individual to express consent. And checking that box is an example of a process. If providers do not have a HIPAA compliant telehealth platform, consent can be captured by having a second employee hear a member's verbal consent and sign and date a witness of consent statement that is then stored in the client's record. Again, the key here is just to have an audit trail in place that can be stored in the member's record. Another option is sending the client a text or email as a virtual check-in that requires the client to reply with consent for treatment prior to initiation of services. Services that cannot be provided by telehealth or audio only if there is not the ability to document that consent as outlined here. Providers will not be held accountable to meeting these requirements until the end of the year. With that being said, providers should be meeting or working towards meeting these expectations. So let's talk about signature requirements on treatment plans when services are being rendered via telehealth or audio only. Again, there was some flexibility previously afforded to obtaining signatures on treatment plans that it could be verbal. But moving forward, treatment plans are required to have an individual or parent signature attached to the attached to the record according to level of care specific requirements. So the signatures must be obtained using either a HIPAA compliant telehealth platform or by acquiring signatures via US mail or email. The signature should be in place as soon as possible, but no later than 90 days after the service date. Just as with documentation of consent to receive telehealth, it is preferred that providers implement a HIPAA compliant telehealth platform, and having some sort of checkbox, as we just talked about, as a method to capture that consent is permitted, as long as there is also an option to not accept the treatment plan. All right, let's discuss signature requirements and encounter forms. Audio only verification for service encounters must be obtained either by having another employee of the entity here, again, meaning two people, and documenting that consent, or by utilizing a mechanism such as a telehealth platform or US mail or email to secure consent. Services cannot be provided audio only if there is not some ability to document the verification of services. Providers, again, should not bill for services unless they have verification of the service. For our last slide on telehealth, we just wanted to share some telehealth resources. First, we've included the link to the OMSAS telehealth FAQ. We reviewed many of those questions on these slides, but please utilize the link to access that full FAQ. In August, Magellan issued a provider communication that links providers to the new telehealth bulletin and the OMSAS FAQ. In this communication, we also reviewed the billing of telehealth that I just talked about, the place of service codes, and the FQ modifier. And then as a final telehealth reminder, Magellan has telehealth provider performance standards posted on our website. These really provide some helpful guidelines and technical assistance to providers on all aspects of telehealth delivery. So now I'm going to pass it to Holly for some more poll questions and some Q&A as well.
Thanks, Carly. All right, so we have 3 questions on telehealth. I'm going to launch the first one. Under the new telehealth bulletin, verbal consent is allowable. True or false? All right, I'm going to end the poll and share the results. So this one's a little bit of a trick question, but the answer is true. If that consent specifically is recorded electronically or witnessed by a second employee of the provider, and the provider has a system in place that allows an audit trail to validate the signature's identity, then that in fact is true. Our next poll. Which place of service code should be utilized when telehealth is provided to an individual in their home? All right, I'm going to go ahead and end the poll. The answer to this question is 10. And our third poll for this section is under the new telehealth bulletin, what is the maximum allowable time that is permitted to obtain treatment plan signatures? I'm going to end the poll. The answer to this is 90 days. Here's the results. All right, now it looks like we have quite a few Q&As in the mailbox at the moment.
Yeah, I'm going to start going through some of those and answering them in writing. I did just answer one related to unlicensed clinicians who are under the supervision of an LCSW or LPC and whether they can provide outpatient behavioral health in a, again, in a licensed outpatient clinic. They would need to meet the criteria of a mental health worker or a mental health professional. So you would want to reference PA code 1153, 1223, or 5200, depending on if it's a mental health clinic or a DNA clinic. But as long as they meet the criterion definition of a mental health worker or a mental health professional, and you have the appropriate staffing ratio in your clinic, clinicians can be unlicensed. They do not have to be licensed. I'm going to pass it now over to Diane to do an SIU presentation. And as I said, I'll start going through some more of the open questions.
Good morning, everyone. I just wanted to talk to you a little bit today about the SIU and special investigations and what we do and, you know, what our purpose in life is and how we go about it. Our objective is to identify and mitigate fraud, waste, and abuse in all of our service delivery programs using a dedicated cross-functional team and a coordinated approach. Our efforts to serve to support a high-quality network of providers and reduce the risk of fraud, waste, and abuse in the Medicaid system. So everybody in the network gains from improving the exposure to fraud, waste, and abuse issues. We have a higher quality level delivery of services to our members, and our network is significantly improved by those efforts. So it's to everybody's benefit to identify fraud, waste, and abuse. Our challenge is doing that. As an industry, the current estimates of fraud, waste, and abuse in healthcare range from about anywhere from 3 to 10% of expenditures, and they can be as high, or they're estimated to be as high as $3 billion, according to the National Healthcare Anti-Fraud Association. So that's a huge eye-opening number that, charges us with an important responsibility to reduce that number and to reduce our exposures and risk to that type of activity. Resources that we bring to the table for this come from clinical, investigative, administrative, data mining, data analytics, and programming resources to aid in the planning, development, and execution of our FWA program. Next slide. So some of the tools that we use to get that job done, to minimize those risks and identify them. A lot of our work is based on referrals that we receive, and they can come from hotline calls or whistleblower reports, data analytics, reports from audits that the auditors have conducted. Identifying trends in data mining is also a basis for some of our investigations. The SIU work plan is created in collaboration with corporate leadership and examines new and existing program risks. So that's something that's always evolving. The SIU develops and maintains a library of contractual and regulatory references that are considered during medical record reviews, audits, and data analysis. The SIU coordinates with the network and quality departments, as well as claims and compliance auditors, to employ mitigation strategies such as provider education and corrective action plans. The SIU conducts root cause analysis when issues are identified to control process weaknesses and maintain the integrity of investigations and recovery of overpayments identified as a result of fraud, waste, or abuse. Next slide, please. So talk about data analytics, and this is a field that has grown enormously. At one time, we mined data, we looked at claims and we looked for people that were anomalies for like certain things like overall usage, the volume of claims, the hours worked on Saturdays or holidays, and just these individual variables. But we have gone way past that now, and we have a number of pilot programs in place in which we are utilizing, working with data scientists to create algorithms that will tell us where we most likely are going to meet these fraud, waste, and abuse issues and where we're going to be exposed to them. So it starts to build like this composite model of the provider that might be engaging in the things that place us at the greatest risk. So this slide shows you that we go out, we talk to everybody, we talk to quality, we talk to clinicians, and we identify where these risks lie. And we look at things and we say to them, in past SIU history for cases and investigations, what have you seen the most frequently? And it starts to build that algorithm that the scientist is going to apply to the data. And you see here a percentage of members billing more than 8 hours a day, 40 hours in a calendar week. You also see the holiday and weekend things. You see certain modifiers can be identified that show up with frequency in cases that wound up being fraud, waste, or abuse. The total numbers of members seen, the average cost per member, the average hours per member for all the codes. So we start to build this model, and it identifies for us providers that are hitting in all of these fields with the highest consistency. And then those providers are identified for things like proactive audits and future data mining and just like closer monitoring of their claims. So these algorithms allow us to understand better where our risks are occurring and how we can best minimize them. It allows us maybe to look forward and prevent fraud, waste, and abuse, as opposed to always like, chasing after payments and identifying after the fact. So we're very excited about this, and that's occurring as we speak. Next slide, please. So a little case to talk about for a few minutes. These are the actual things that happened, and you'll kind of see our process unfold inside of the story. Kathy was an individual outpatient practitioner, and one of her members got an EOB in the mail. The member knew she only saw Kathy occasionally and never for 15 or 20, more than 15 or 20 minutes, but this did not match what was on her EOB. So Kathy was audited and provided acceptable documentation for most of the records that were requested. There was a small overpayment for documentation errors and missing documentation that was collected. So it's a very routine thing. The member saw something and didn't match up on the EOB, we go to the provider, produce the documents, and we review them. So later that year, another referral comes along about Kathy. And the member reported to their care coordinator that Kathy contacted the family on Facebook and requested they open a bank account so the provider could charge Medicaid $1,000 for services and then would reimburse the family $600. So we had a little kickback going there. This couldn't be confirmed as a credible allegation of fraud doing that investigation on that referral. So the investigator verified with the member and his family that all the services that they were received and paid for, they actually did obtain and they were rendered. And we reviewed that documentation. So there was actually no overpayment identified for that. And the whole issue of whether there was some type of kickback offered or some type of bribery by the provider at that time, we could not tell. Next slide, please. So Kathy went on to, render services and stay in business as an individual practitioner. 2 years later, another member reports that she does not see the provider as frequently or as long in duration as her EOB states. A new investigation determined the provider was billing for couples and or family therapy with the CPT code 90847, but rendering individual services instead. Documentation received did not support more than one person ever being present or in the sessions or discussed during the sessions. Further investigation determined the provider was fraudulently billing Medicaid for children's counseling sessions when in fact public school records showed that the children were in class attending school during the alleged counseling sessions. So here's where you start to see an investigation expand out past the parameters of what you're initially looking at, which is often the case, particularly with someone like this who was, committing fraud, waste, and abuse. For us, we were able to expand this out once we got into the records. And now we see not only was the family therapy an issue, but now we have kiddos who are actually in school being billed for sessions. So then you start to, reach out to your law enforcement agency partners because now you see proof of real fraud. So eventually the provider was accused of illegally billing the Medicaid program and faced 15 felony charges, including multiple counts of fraud over $20,000, obstruction of investigation, medical fraud, and theft of identity. She was ultimately sentenced to 3 years in the Department of Corrections and immediately remanded to custody following her trial. She is in custody at this time. Next slide, please. So we take the allegations of fraud very seriously. We always come at things, though, with a positive intent. We don't make assumptions and we follow where the documentation leads us. And everything that we do is fact-based. But we do investigate every allegation and we take them very seriously. Some reporters are more credible than others. We don't speculate on motive and we just investigate what we're given and what we're told. These are some examples of things that led to fraud, waste, and abuse cases. It's someone that called in and said they ran into one of their former patients. This was a clinician. And she asked the patient, oh, well, yeah, they were talking, and how do you like the new, therapist, and what's his or her name? And the name that they gave her was really rang a bell with her, because it was someone she knew had left that provider years ago. So they were using the credentials of someone that had left, and that is actually more commonly occurring than you would expect. So that was an allegation that opened up a fraud, waste, and abuse case. We have constant reporting from either current or former employees that people alter their records, have charting parties, don't supervise, update treatment plans, and someone stating things like, I know 2 people who work don't have credentials. So again, these are all things that can be proven, and we follow where the documentation leads us, and we investigate every single one of them that we receive. Next slide, please. So that's, some of the ways that things feed into us and the tools that we use to get our job done. We can't do that job without you. It's all of our jobs, right? And it's to all of our benefits to identify, prevent, and uncover fraud, waste, and abuse. Recover Medicaid monies that were inappropriately, paid out. So we need you to do that as well. So when you, as the saying goes, see something, say something, and we will always check it out. So thank you for that. And I'll send this back to Carly.
Thanks, Diane. There is one question here that I'm hoping you can address. The question was, why do you not allow anonymous SIU referrals?
Okay, actually, we do allow anonymous referrals, so I'm not sure what that's based in, or who might have told you that, or what you might have experienced. Obviously, it's easier for us when someone sends in an allegation and it's kind of generalized, and we're not allowed to speak to you or recontact you. It makes it difficult for us to sometimes proceed with those allegations. But if you do you choose to provide your identity, and you choose to provide contact information, it's always kept confidential within the SIU, is never shared outside of our investigative team members. If you do wish to remain anonymous, that is also certainly acceptable.
Thank you, Di. I'm not sure if attendees can see. I'm getting some questions about how to see the answered questions that have been answered in writing. I'm not sure for attendees when you open the question and answer, there should be multiple tabs for open questions and answered questions. So if you want to see the questions that have been answered in writing, you should be able to click on the answered tab. If that's not an option for you, I apologize. We will, as I said, be sending a list of all the questions and responses to all participants following the training. So again, apologize if you can't see them, but in order to keep this training going, because we have a lot of content, we're trying to answer most of the questions in writing. I am going to now pass it over to Patty, who is going to share some resources on E&M.
Thank you, Carly. All right. So I just wanted to highlight Magellan's stance on E&M coding, evaluation, and management is what E&M means, standing for. So E&M coding follows what can be found in the American Medical Association's AMA code and guidelines. We want to specifically call attention to the fact that E&M medical decision-making is meant to be determined by the medical or behavioral professional, and an electronic health record, or EHR, should not be configured to replace that decision-making component. Likewise, time spent in itself has never been the only consideration in meeting certain code criteria. The key component is that, however, a medical behavioral professional establishes the appropriate E&M code, in accordance with these guidelines. The documentation in the medical record must support and justify that determination. Next slide, please. I just wanted to share with you a couple of resources for coding and evaluation and management resources. So here are some resources, which one of them includes an E&M calculator and the other is codified by AAPC. So I just wanted to share those with you. At this time, those are a few resources that we have, and I'll open it up for any questions or Q&A at this point.
It does not look like there's any questions specific to E&M. It does sound like attendees cannot see the answered questions. So again, we apologize for that, but we will be sharing the complete list of questions and answers, and any questions that we're not able to answer during today's session, you will receive a written response following the training. So now I am going to move into some confidentiality reminders. Just a disclaimer to start is that we are not furnishing legal advice. If legal or other guidance is required, providers should consult with their legal counsels. So just some basics to go through quickly. Confidentiality of information about a member receiving mental health or substance abuse treatment services is a critical component of the work we do on a daily basis. Confidentiality is an ethical obligation of all treatment professionals and a legal right for every member, regardless of the source or the format of the information. Everyone is familiar with HIPAA, federal law that guides what information can be shared and with whom, but state confidentiality laws, as well as the federal substance abuse law, may be more stringent than HIPAA, and you must follow the most stringent law. Providers are responsible for knowing, understanding, and following all applicable laws regarding confidential patient information, including any applicable reporting requirements for child or elder abuse, and the common law or statutory duty to warn. These requirements are outlined in your Magellan Provider Handbook. Providers are covered entities under HIPAA and therefore must follow all applicable regulations concerning reporting requirements. Please note that providers do not need to report their own HIPAA violations to Magellan. You should just follow the HHS requirements for reporting any confidentiality issues. You do not need to also report those to Magellan. So now that we've reviewed some confidentiality basics, let's talk about care coordination. What's the benefit of this practice? We all entered the healthcare field to serve people and to ensure that they receive the highest quality care possible and make progress towards recovery. In that process, we want to always protect an individual's private healthcare information in accordance with the laws and regulations while obtaining the necessary consents in order to coordinate care. Care coordination is critical to an individual's recovery. When we coordinate care, we avoid Medicaid waste by not duplicating work that has already been done by another healthcare provider. We ensure that prescription medications are not overused or misused. And we ensure that there aren't conflicting treatment or care plans. In this way, all healthcare professionals that are supporting our members will be working together in the best interest of the individual. Care coordination improves access by allowing for communication between providers and could assist in removing any barriers with referrals to higher levels of care if that's needed. We often have members, sometimes these are children and adolescents who are waiting for an acute inpatient hospital bed. And one of the core reasons placement might be delayed is that providers aren't getting releases completed in order to appropriately coordinate care. Care coordination also improves comprehensive treatment. It helps support member access to social determinants of health resources. It helps to ensure that a member's family and or their loved ones are involved in their treatment, and it improves discharge planning for our members. So hopefully that's a good segue into this slide, which is the practical application of how we support coordination of care for members. Before we coordinate care, we have to get the appropriate releases in place. Providers must develop and implement their own release of PHI forms in order to coordinate care with other treatment providers, service systems, and member supports. Magellan has a designated form called our Authorization to Use and Disclose, or AUD form, that allows us to share information with a third party. It also allows us to share prior substance use treatment history with a treating provider. We have multiple options for submitting these forms to Magellan. On our website, there's a fillable PDF form that can be printed and submitted, as well as an electronic submission option. Our online form was actually down for several months earlier this year, but happy to report it is now functioning again. And we recommend that members use the online submission option whenever possible, as it reduces invalid forms. Legal paperwork can also be uploaded through the online portal to help support guardianship. If you're using the fillable form and faxing, emailing, or mailing to Magellan, you need to remember to complete all sections in full. In most cases, members aged 14 and older control the release of their records and thus must sign the AUD. For members under 14, the legal guardian must sign the AUD. If someone other than the biological parent has legal custody of a child, proof of custody must also be provided. And a last reminder about completing AUDs: control of records is with the consenting party. Per Act 65, if a member's legal guardian has consented to treatment for a child aged 14 to 17, the legal guardian would control the records and thus sign the AUDs for that specific treatment episode. So it's some additional information about our release forms. If a providers are requesting written information from Magellan related to an individual's past treatment that might be in our designated record set, those requests can be submitted in writing along with to Magellan, along with a completed AUD or another release form signed by the member or the member's personal representative. We can accept completed AUDs through email, and the email address is shown here on the slide. And record requests, as well as other supporting legal documents, may be submitted also by email to our compliance mailbox, which is on this slide as well. So now we wanted to spend a couple minutes talking about a hot topic from this summer. There was a change in the substance use disorder confidentiality regulations in Pennsylvania. On July 7th, Act 33 of 2022 was signed into law. Act 33 made significant changes to the SUD confidentiality provisions under PA law. Act 33 made our confidentiality regulations consistent with federal law. So federally assisted programs for the diagnosis, referral, or treatment of substance use disorder are covered by federal regulations 42 CFR Part 2. So providers will now follow 42 CFR Part 2 instead of 255.5. We have active hyperlinks to both of those documents on this slide. DDAP also issued Informational Bulletin 02/2022 on August 24th, which outlined which SUD providers were impacted by this legislation. But basically, any provider who receives federal assistance is impacted by Act 33. So that would be any and all PA Medicaid providers. So if you're asking how this change impacts your work with Magellan, hopefully this slide will help. 42 Part 2 CFR still requires that members sign consents to release SUD information. Unlike HIPAA, there are no exceptions for treatment or care coordination or payment. The only exceptions are for medical emergencies, research, or certain audits. Magellan has always required an AUD signed by the member, which includes special permission to share SUD before we would share any substance use information with a third party, including a treating provider. So that will not change with the elimination of 255.5. Likewise, providers need to obtain signed releases from members during admission in order to share information with Magellan, including submitting a claim. If a member is not willing to sign a release to share information with Magellan, then the provider would be unable to submit the claim to Magellan to get paid for services. The main difference for Magellan treatment providers with the elimination of 255.5 is that we are not now able to share more detailed and thorough information. Under 255.5, there was very limited information that could be shared. So now I'm going to pass it back to Holly to do a couple more poll questions.
Thanks, Carly. All right, we have, I believe, 4 poll questions for this section. So here's our first one. In cases where state confidentiality or federal substance abuse laws are more stringent than HIPAA, the more stringent state confidentiality or federal substance abuse laws must be followed. True or false? And the poll, the answer is true. Our next question. In Pennsylvania, at what age does an individual have control of their own health records and therefore must sign the AUD in most cases? 21, 18, 16, or 14? Okay, the answer is 14 years old. Our next poll. All right, third-party requests for member records must include which of the following? Select all that apply. A written request outlining what information is being requested, an AUD completed by the member or the member's personal representative. When an AUD is signed by a personal representative other than the biological parent, legal documentation stating that the personal representative has legal right to act on the member's behalf is required. Some examples of legal documentation would be power of attorney, guardianship, estate, adoption. End the poll. And the answer is all of the above. And our last poll for this section. Due to Act 33 of 2022, which was signed into law on July 7th of this year, Pennsylvania's SUD confidentiality requirements are now in alignment with federal law. DDAP is restricted from implementing any new confidentiality regulations that exceed the federal regulation. True or false? The answer is true. All right, now, Carly, are there any Q&As that we need to address now, or should we move on?
Just one thing I wanted to mention real quick, thanks to all the helpful attendees that did let me know that all attendees can see answered questions. There is a light blue show all drop-down arrow where you can show all the questions that have been answered. So again, thank you to the attendees that pointed that out. If folks want to hit that drop down to show all questions, you can see all the questions and answers right now. I'll continue to answer as many questions as possible in writing, but we are short on time and only have about 1 or 2 sections left. So we want to get through all of the content. I'm going to pass it back to Patty.
Thank you. So I'm going to talk about a little bit about compliance plans, compliance culture, and compliance ethics. So next slide, Holly. All right, again, we aren't going to go into detail today on the now 8 components of an effective compliance plan. But for context, as a means of introduction to this section, we wanted to list them out. The elements of an effective compliance program fall within 3 buckets: prevention, those items in red font, which includes written policies and procedure, designation of a compliance officer and committee, and developing an effective training. Detection, those appear in green font and include having an open lines of communication and internal auditing and monitoring practices. And finally, corrective action bucket, and those items appear in the blue font, establish and maintain disciplinary policies and establish and maintain a system for responding to compliance issues. Next slide, please. Now I wanted to spend a little bit more time talking about compliance culture. A culture of compliance goes beyond a once-a-year mandated training. It is also not just for fraud, waste, and abuse. A strong culture embeds compliance in everyday workflow and sets the foundation and expectations for individual behavior across an organization. Compliance is about the process improvement, not punishment for doing something wrong. For starters, staff should feel comfortable with raising concerns. The ultimate goal is to address the concerns and make adjustments to prevent reoccurrence. It should be open and a safe environment. When we talk about process improvement and developing a strong compliance program, providers should ask themselves, what are they currently doing well? And it relates to compliance, and what don't you do so well? Be aware of your strengths, but also be aware of the needs that you may need to focus and pay closer attention to. Another step to creating a culture of compliance is having a designated compliance officer who can spend the time, energy, and resources needed to execute on the culture. What we see a lot in agencies is that compliance functions are aligned to a staff person who already has another job title and many other responsibilities. Many times, quality and compliance are combined under one person. Last point I want to make is you are probably aware that there's a lot of overlap when it comes to compliance issues. Rarely is anything just a compliance issue. There are typically implications that affect the clinical, finance, quality, and legal and/or HR departments. That is another reason to have a diverse representation on your compliance committee and ensure there is a lot of communication and collaboration between various departments. Next slide. A few more points I would like to make as it relates to promoting a culture of compliance within your agency. Part of having a strong culture is knowing where to find the answers. The regulations, the bulletins, the FAQs, and other guidance are endless in the PA Health Choices Medicaid program. Nobody knows it all, and we don't expect you to, but you need to know where to find the information, and you should have an innate understanding of the core risk areas and requirements. A successful compliance culture is strongly influenced by how much staff trusts their management. This includes open communications, keep promises to staff, maintain a high degree of ethics, do the right thing even though it's not easy or could have implications, be consistent, which builds trust, and report to your staff, support your staff and respond to their concerns. It is also important to remember that compliance is more than just billing. Training and culture helps make your team aware of all components. It's a simple formula. Increased compliance leads to increased quality. This is based off the premise that the regulations and requirements are there for a reason. And increased quality means that you will be a provider of choice for our members. Next slide, please. Now I'm going to talk a little bit about some common items missing from the compliance plans as from audits we had conducted. So one of the things that I did discuss earlier regarding compliance culture is the comparison of clinical documentation versus accuracy of billing, and meaning that compliance isn't just billing. So there means to be more than seeing just a progress note for the date of service billed. We're really looking for documentation to support that billing and to support the number of units that are billed. We want to ensure that progress notes are, and I'm using air quotes, telling the story so an outside reader can have an understanding of what is actually going on. Annual reviews of the compliance plan and documentation of that annual review. We know everybody always has their annual review of their policies, but we're also looking for that documentation of that annual review took place. Internal investigations, when should it be conducted, the time limit for it, and action steps. Also regarding reporting to the BHMCO and to OMSTOS on findings. And providers should have a policy procedure on when an investigation should be performed by an external investigator. One of the other things that we take notice is outside resources for reporting fraud, waste, and abuse, such as state, county, and MCO hotlines. And also another thing that is very common is the legal ramifications of fraud, waste, and abuse. Most staff are aware that they can be terminated or lose their job. However, there are legal ramifications such as jail and fines. Next slide, please. And just a reminder on compliance interviews reminder, as a part of our audit process, we like to gain knowledge on the compliance culture of the agency. So we ask for providers to hand out 5 to 8 surveys to their staff to have questions and answered. We want to just remind folks that the responses are for education purposes only. Ensure that the survey is completed in full. And if do not leave any sections blank, put an NA if it doesn't apply. And the surveys are also sent out with the audit confirmation, and they are due 1 week prior to the audit. It really gives a nice snapshot of what the frontline folks see and what the actual staff see. And I think a lot of our providers can use it as a learning tool with clear communication with their staff. Next slide, please. I think that is any questions or any poll questions we may have, Holly.
Yes, thanks, Patty. I'm going to go through these very quickly because we are running short on time. We want to be sensitive to everybody's time here. So our first poll question is, what are the potential consequences for committing fraud, waste, and abuse? And the answer is all of the above. Our next question is, which provider types are required to have compliance plans? The answer is all providers. What reporting options for fraud, waste, and abuse should providers utilize? This is a multiple choice question. Okay. The answer is all of the above. Next. Providers should outline in their compliance plan or policies when to engage in an outside auditing consulting firm. True or false? The answer is true. And our last poll for this section. The workflow for internal compliance investigations should include the following. Plan that addresses how internal investigations should be conducted. time limit for closing a compliance investigation, options for corrective action that the agency can take, when to have an investigation performed by an outside independent investigator, and all of the above. And the answer is all of the above. All right, I'm going to turn it over to Tina to talk about some other reminders.
Thanks, Holly. Next slide. So we just want to quickly review self-reports for FWA. It is important for providers to self-audit their programs according to their policies and procedures. When potential fraud, waste, and abuse is found as a result of these audits, providers are to report these discrepancies as well as any overpayments to Magellan and to the state. There are several items that need to be included in the self-report provided to Magellan. The self-disclosure spreadsheet is an Excel attachment. If you do not have that from the past, we are more than happy to send that to you. All you need to do is email one of us, as well as the investigative summary that should be included. At a minimum, the slide lists the things that should be included in that summary. All reports of your self-audit should be submitted to our self-report mailbox at PAHS self-report@magellanhealth.com. Next slide, please. The difference between self-reports and corrected claims. The provider self-disclosure claims recovery template should only be used when you are letting us know of an overpayment or potential fraud, waste, and abuse. It should not be used for a corrected claim. Instead, billing mistakes or errors should be corrected using the Magellan's claim resubmission process, whereby a provider can submit a corrected claim, and you can find the details of that in Magellan's Provider Handbook Supplement, page 74 for details. Resubmitting claims with provider billing errors are called resubmissions, and resubmitting claims should be received by Magellan within 60 days of the date that you determined that it was a mistake. Next slide, please. Just a few other resources or reminders that are found on the PA Health Choices website. FWA compliance page gives you resources, compliance best practices, audit tools, training, education, and how to prepare for an audit. Also on the website is compliance email blasts. Those are issued monthly via email and are posted under the compliance alert section page on the website. These email blasts address important regulatory and Pennsylvania Health Choices guidelines, including recent audit trends and policy changes. So this is a good source of information for you. Provider trainings are also on the website, ongoing trainings for new and existing providers. So check that out. And also the Provider Handbook Supplement is on the website. It's an important requirement, or it gives you important requirements and guidelines for all providers. Back to you, Holly.
I'm actually going to jump in here as we are a couple minutes over, so we're just going to move into our closing here. Thank you everyone for hanging in with us, and sorry we've gone a couple minutes over time here, but here it's just a snapshot of how to get in touch with us. So if you do have questions after today that weren't answered, or you have any other questions at any point, please feel free to outreach to any of us directly. In terms of what's going to happen next, we will send a copy of this PowerPoint, the Zoom recording, and the Q&A to all participants in the coming week. If you have additional questions, please feel free to outreach to us. Providers should also be on the lookout for an upcoming survey to give us feedback and provide suggestions for future training opportunities. Again, we really appreciate everyone's time this morning. We hope the information that has been presented has been helpful within your provider agencies. There was a lot of questions that came in today, way more than we expected. So we apologize if we weren't able to answer everything live, but we will get back to you. And thank you again. I hope everyone has a great weekend.
Bye.